All right. Good evening, everyone. We are right at 6 o'clock and we like to start on time. We're so excited for the webinar tonight. Thank you for joining us. This webinar is just for us women. So I am personally excited about this content. Today's topic is Understanding Your Body, a woman's guide to pelvic and sexual health at every stage of life. And this is part of our ongoing Ask the Experts webinar series that Urology Austin brings to you every single month. Just a few housekeeping items for the night. We will start with a presentation, and I'll introduce our doctor this evening in just a few minutes. But I want to make sure that you know how to submit questions if you have them, because I know you will throughout the webinar. So at the bottom of your Zoom screen, you should see a Q&A button. And if you don't see it, you can click on the more with the three little dots and it'll bring up a window and you can select Q&A, and that is where you will submit your questions throughout the webinar. And then at the end, we'll answer those live. So you have an opportunity to get some of your most pressing questions answered right in this forum. And so be sure to submit those as we go along tonight. Well, just a little bit about Urology Austin. Urology Austin provides comprehensive patient-centered care across every aspect of adult urologic health. Men's urologic and sexual health, women's urologic and pelvic health and sexual health, and the diagnosis and treatment of urologic cancers. And they have locations across Central Texas and Austin. And so you can check us out at urologyaustin.com to see the location closest to you. Well, I want to take a moment and introduce Dr. Hardee. And so Dr. Miranda Hardee is a board certified urologist who really specializes in treating both male and female urologic conditions. She focuses on improving a patient's quality of life through advanced and compassionate care. And so just a few things about Dr. Hardee. She's board certified urologist. She trained at the University of Florida and the University of Utah. She specializes and has special interest in female urology, and why we are all here tonight, including things like recurrent UTIs, overactive bladder, incontinence, and a lot of those topics that we as women talk about together when we're around the dinner table with our friends and our close family members. And so she's going to dive into those topics tonight. She's also been recognized as an Austin Monthly Top Doctor and a published researcher on urologic care. Dr. Hardee, I'm going to hand it over to you and let you take it from here.
Okay, thanks, Jamie. I'm going to take this off of my screen. Sorry, I just had some fun pop-up come on. There, I can't see us. That's okay. There we go. Now we're back.
You have to love technology sometimes.
I know. And now, do I still have control of the slides? Doesn't seem to be.
So you should have, let's see, go ahead. There you go.
Okay, good deal. Okay, perfect. So this topic, as Jamie and I were discussing earlier, is a really big topic. In fact, it's going to go from pediatric urology all the way to the menopause years. And as she mentioned a few moments ago, these are topics that some of us are aware of because they're very common. They may be that we leak after we laugh, cough, sneeze once we've had babies. But there are going to be some of these topics that are a little more intimate, and maybe we're not comfortable talking with even our primary care or gynecologist about. And so we're going to dive deep into some of those things that really affect all of us. And then hopefully at the end, you'll feel you have a really comprehensive understanding of how special we are as women and how blessed to have these changes throughout our lives, but also to know what treatment options are available, and then kind of to help you understand what is normal, what is expected with aging, what are things that you really should be proactive about in preventing or even treating. So with that, we're going to jump right in. So let's start, we're going to go in a chronological order. We're going to start the pre-menopause years. So the first thing that I want to bring up, and this is very common in my younger patients, is urinary tract infections. And we'll address this later in the talk as well, at a different decade in our lives. But some urinary tract infections can present in childhood. There are a few anatomical conditions. One is called vesicoureteral reflux. And just briefly, that's where the bladder, as it distends, urine should not shoot up to the kidneys. But if this happens, then you can understand why someone may be at a higher risk for developing infections, including kidney infections. As a child, if you're that unfortunate female, then that can put you at increased antibiotic exposure as a kiddo, many UTIs, even urologic surgeries. And just those risks themselves can translate later to being at a higher risk for developing UTIs in adulthood. The other thing that kiddos deal with, which also can carry over into adulthood, is habits. So basically, bladder and bowel dysfunction. We can all think of maybe even our own kids or ourselves where we may used to hold our bladder for long periods of time at school. You didn't want to use the potty, or even you were afraid to have, a number two and leave class. The problem with that is those habits start early. And it can make it where it's very difficult for a child to empty their bladder, which can cause leakage later. It can also contribute to them getting more urinary tract infections. I bring this up only because I have patients all the time tell me, like, oh, yeah, I can remember that my parents wouldn't stop on car rides. And so we were forced to hold our bladders the whole time. Well, believe it or not, that even at that time can distend the bladder or stretch it out to where later in life people have issues. Moving on in to our teens and 20s, when we become sexually active, urinary tract infections are very common to occur around intercourse. And we hear all kinds of things. I shower before, I shower after, I'm very careful. My partner is very careful. This is not a hygiene thing. And to be honest, we really don't know why some women are plagued with this versus others. My assumption is that some women, their vaginal pH swings more towards the basic side. And what that does is it creates this imbalance of bacteria where the bad are outweighing the good, which we'll talk a little bit about later as we discuss the menopause changes. But those women probably are more susceptible to UTIs related to intercourse. I think there's probably a genetic component because lots of young ladies say my mom dealt with this issue. There probably is a part of science we don't yet understand, meaning that not just a genetic part, but there's a cellular component where bacteria stick to the lining of the bladder more for some women than for others. Birth controls can also weigh into this. So any hormonal birth control for some women can increase a protein called sex hormone binding globulin. What that does is it binds up to free estrogen. So even though here I am at 22, I should have no problem with my hormones. But let's say I've been on a birth control that isn't, impacting that, then it can kind of change the environment of my vagina to behave like it's menopausal, meaning that sex hormone binding globulin can bind up to some of those free estrogens and can swing the pH again to where it's more basic. It can increase my risk of UTIs, bacterial vaginosis, and yeast. I will say that on this front, some things have changed. We do have some better testing now to look for bacteria that maybe we didn't recognize a decade ago as causing problems. These are more atypical type bacteria that we can offer special testing for. And interestingly, we're becoming more aware of which type of those bacteria that we also need to treat sexual partners. So bacterial vaginosis being one of those, just released in October, that we should be guiding patients, we should be treating their partners as well. So that's the premenopausal UTI summary. Now we're going to move into incontinence. So I want to give you just a brief definition of the two main types of incontinence we will see here. Stress incontinence. So this is when I cough, sneeze, laugh, I leak. And the reason that happens is when there is an increase in my abdominal pressure, then that pressure is higher than the ability of my little Kegel muscle to close. So I leak. You have urge incontinence. And so this is when I get the urge to go and I can't quite get to the bathroom. I'm going to go back. Sorry, just this slide real quick. Yeah, perfect. There we go. And so with this urge incontinence, you get the urge to go. And then by the time you get there, you're leaking or you're about to. So in premenopausal women, stress incontinence, the coughing, sneezing one is more prevalent, but combined, 25 to 40% of premenopausal women will have some leakage. And it is not uncommon that I meet a woman who says, I've actually been having this problem since I was a soccer player in high school, or this prevented me from going to spend the night at a friend's house. All of this matters because being aware of that childhood trauma sometimes changes our bladder habits later in life as well, or certainly makes us more sensitive to those, and it can be more challenging to talk about. So overactive bladder, while it is more prevalent post-menopause, definitely we see all the time earlier in life as well. And this may present as I have to go more frequent. And normal, just so you know, is about 6 to 8 times in a 24-hour period. I have to wake up at night to urinate. Over the age of 40, once a night would be considered normal. But if you're waking up more than that, that certainly could indicate there's a problem. And I need to go urgently. Sometimes I have this overwhelming urge to get there. When I get there, there's really not much there. Overactive bladder, it is a primary condition, but it also can be a group of symptoms related to certain lifestyle habits, which I'll jump into. So, for example, unfortunately, our lovely teachers, so educators, people that work in factories, people in healthcare that have to hold their bladders for long periods of time, those career habits can translate into a greater risk of UTIs because it's like, and I use this analogy all the time, my patients listening will know this, but it's like a stagnant pond versus a flowing river. So not only are they at increased risk for UTIs, but years of holding their bladder to large capacities can result in their bladder not working very well. And that can mean sometimes that they don't empty as well, but it also can mean more frequency, urgency, kind of developing a spastic bladder. Those same careers, and sometimes people, it's just a lifestyle choice, decrease hydration. Because if you have a classroom full of kids and you know you're going to have to use the restroom, you intentionally may not drink very much water because you don't have the opportunity to go. So decreased hydration obviously can result in an irritated bladder at times, more UTIs. Some of us just drink more caffeine. Sometimes it's because we have 3 kids. Who knows? But that also can result in a more overactive bladder because caffeine is not only a diuretic, but a bladder irritant. So more frequency, urgency, those things may result. I put travel on here because with travel, people are at a higher risk of UTI. We see it all the time. And often that's because they have to hold their bladder for longer periods of time on a flight, a long car trip. Maybe they're drinking more wine and coffee than water. But I think it's an important thing to remind people of. The next bullet point, pelvic floor dysfunction, could be an entire talk in itself. I want to explain what that means. So basically, your pelvic floor muscles, or what I call the bottom of the basket, they're the shelf of muscles that are supporting my entire body, essentially. But locally, they're supporting my bladder, my uterus and vagina, and my rectum. So they're working all the time. When I'm sitting, they're engaged. When I'm walking, they're engaged. Some of us have a natural tendency to hold more tension there, just like I would up here. When there's tension in that muscle group, it can mean pain with intercourse. It can mean that you have difficulty eliminating your bowels or your bladder, because if I need to urinate or if I need to have a bowel movement, but my muscles don't relax, I'm not very effective at doing that. And then again, that leads into this cycle: constipation, not emptying my bladder, more UTIs because I'm not able to empty as well, or even just the muscle groups themselves being very tense and tight. It creates this very tight network around my bladder. So my bladder can't relax as it needs to. Then I have more urgency, more frequency, those types of symptoms. So that's a really important one. Um, Pain with intercourse, beyond just due to pelvic floor dysfunction, can sometimes present because women have specific conditions involving the nerves and the opening of the vagina. A specific condition is called vulvodynia or vestibulodynia, but that can also relate to women having less estrogen in the area, but also may be related to more tension in the pelvic floor muscles. Um, the last item there, there's specific medical conditions that can make all of this worse. So, for example, pregnancy, duh. It's because for almost 10 months, we're putting an extreme amount of pressure on our pelvic floor muscles, and it can take up to a year for that to recover. Sometimes it doesn't go back to normal. So, that can increase our risk of leakage. Um, I bring up miscarriages. I mean, a lot of us have had them. And I bring that up because it just highlights another unpleasant experience that can occur during our lives in our pelvis. And sometimes that can make it where we're not really interested in for intercourse for a period, or there's some trauma related to the pelvis, which can cause us to hold our pelvis more tightly. Endometriosis for certain, which makes sense. You know, endometriosis, for those that have it, they have a tremendous amount of pelvic pain, mostly because it's a condition where there are flares in endometrial tissue that is outside the uterus. It should be contained in the uterus. But during certain parts of their cycle, they have terrible pain, and it can form scar tissues, adhesions, even to the bladder and the bowel. So that also can, be something that affects women during this time in their life. And then we already hit constipation. So when you come to our office and you're a little sensitive about, no, maybe you're not seeing people in your age generation in the waiting room, just wait. Somebody's going to come in that matches you, because I guarantee that all of us ladies, if we haven't been through this and aren't walking through the door that day, we will the next. So yes, don't discriminate against yourselves because you think that you are too young or too old for a certain condition. Okay, so it was a lot of premenopause. So let's move forward here. So we're going to expand on a lot of the things we already talked about and how those risk factors and treatment options may change once we enter menopause. So we'll hit UTIs again. We'll also go over the overactive bladder, stress incontinence, pelvic prolapse, and then lastly, vaginal atrophy and the consequences of that. So some women will never experience UTIs until they hit menopause, which we'll explain on the next slide. So they don't really know what's going on when these symptoms occur, but it may present as frequency, urgency, burning with urination, leakage, cloudy urine, even urine that has a bit of an odor, pelvic pain. And then for those who are unfortunate and may have a kidney infection, fever, chills, back pain, cognitive changes. Medicare data suggests that the visits to the doctor for UTIs only account for 6 to 8% of all doctor visits in the Medicare population. It's tremendous. It also accounts for an expense to our healthcare system of almost $2 billion a year. So it's extremely frequent. And interestingly, in researching for this presentation, I learned that really the incidence of UTIs have gone up by 10% in pretty much the last decade. So there's a lot, that's going on in the UTI. I guess the problem, and I won't say network because we don't have a ton of quick fixes for those very complex issues to our healthcare system. But moving forward, why do peri and postmenopausal women seem to get more UTIs? And I put peri and postmenopausal there because, as many of us in our 40s know, while the average age of menopause is 51, there's going to be a period where things transition. This doesn't happen overnight. And so women can start to get more UTIs as they are experiencing a transition to menopause simply because there's less estrogen than there used to be. So if you think of the vagina as just a warm, moist pocket, which it is, good and bad bacteria live there. When there is less estrogen, the pH swings to the more basic side. And so that takes a balance of good bacteria and depletes it. So now we have a very imbalanced normal flora where the bad bacteria are winning. So this is going to increase your risk of UTIs. We may have never ever had them before. So the power of estradiol is real. Being able to replace that local estrogen can really help fix the problem. If you are on hormone therapy, such as, an estradiol patch, oral, even creams that are not in the vagina, unfortunately, that will not fix the problem. It really has to be something local. And so the use of vaginal estradiol, contrary to what a lot of people think, it's very, very safe. And I encourage all women to at least consider it. It's going to come in the form of a cream, an insert, like a little suppository. This is something you usually do 2 to 3 times a week, but it's a local absorption. So it's just going in the tissues there, and it's going to help balance out the good and bad bacteria. We even let our breast cancer patients use this. Of course, we do it with the blessing of their oncologist, but it is on the list as an acceptable treatment for those patients as well, because it's not fair for them to suffer. Probiotics I put on there because it's another way to try to help balance out the good bacteria, but you don't want one that's a digestive probiotic. Obviously, you're going to look for something that says like women's health or for vaginal flora. A couple good brands, Refresh, Metagenics, Eucora has a good one, Claire V, which is by Bonafide. Those are all very good ones to use. And specific to the individual, sometimes we do use preventative antibiotics around increased risk times, like with intercourse, travel. We do have options as well that are not antibiotics, but we consider them to be like urinary antiseptics to help adjust the pH of the urine to further help decrease UTIs. So we'll move beyond that and get into another very broad topic within a broad topic. So overactive bladder, incontinence, and pelvic prolapse are all going to be more prevalent in the menopausal years. And just to kind of review symptoms here. So we talked earlier about stress incontinence versus urge incontinence. To remind you, stress was a coughing, sneezing, the muscle weakness type incontinence. Urge incontinence was the gotta go, gotta go. So stress incontinence can be worse during menopause because taking away estrogen is like taking away steroids from the bodybuilder. So innately, those tissues are just going to become more weak. And so that can lead to more leakage. Obviously, it could lead to a greater risk of pelvic prolapse because the tissues are not as strong. Overactive bladder issues tend to increase not only because of that, but embryologically, our pelvis is derived from an area that basically we call it the urogenital sinus. And that's going to later develop when we are embryos into our urinary parts and into our female parts. So there are a lot of estrogen receptors on both of those organ groups. And so with less estrogen, not only can you experience thinning of the urethra, but you can also develop an unhappy bladder. Because the needs of those estrogen receptors are not being met, the bladder can become more overactive, more frequent, those kind of things. So we're going to now go into each of those individual items and just talk about some treatment options. So with overactive bladder, lifestyle changes are something we mentioned earlier. So being aware of your habits, decreasing caffeine. Believe it or not, for some people, something as simple as lemon juice in their water or drinking more sparkling waters can serve as bladder irritants. And that's not for everybody. So please don't go to the grocery store afraid to buy all the things that you love to eat and drink. It's just being mindful of if you had a worse day. Man, I really had to go more often last night. What, did you eat or drink? And that could be in, addition, spicy foods, acidic foods, sometimes even new supplements. For some people, vitamin C can be an irritant. So being aware of that, don't hold your bladder for too long, but in the same respect, don't always follow its lead. What I mean by that is try to exercise some behavioral training so that every time you look at a bathroom, you don't feel like you have to urinate. So a good tool is if you think you have to go, try to distract yourself, 2 to 5 minutes. Start with baby steps. And then if you're able to do that, then work your way up. Because what you don't want is to develop a really strong connection between the brain and the bladder so that every time you see a restroom or think about going, your bladder contracts and you leak. Pelvic floor physical therapy is tremendous. We're blessed in this part of Texas, and then we have a lot of physical therapy options. They're all very good. We have physical therapists in-house. We use several community physical therapists. They're all female, so they're very experienced in these things. But usually with overactive bladder, they're going to help you balance, like, how do you improve your strength and ability to hold, but also they're going to work on making sure your muscles are not too tight. Because again, if the muscles are too tight around the bladder, it can transition into your bladder being very spastic. Medications, there are two very good medications, Gemtesa and Myrbetriq. I won't go into the other drug class because I don't like them. They're called anticholinergics. They were the first ones we had. And to be honest, for some of my patients, they do work best. So some of you may be taking them, and that's okay. But they do come with an extra risk of side effects for some people. And that could include dry mouth, dry eyes, constipation, and some of them maybe even an increased risk for cognitive decline, later 65 and up. The challenging part is insurance sometimes only permits us to use those medications. But again, our preference is to use a group called beta agonist, which how those work is they're telling the bladder just to stay relaxed for a longer period of time in its filling phase. Botox, very, very popular. We've been using Botox to relax muscles in medicine probably close to 30 years now, maybe even longer. But how it's done in the bladder is you come in. Most people do this in the office, but it can be done in the operating room. Put a numbing solution in the bladder, and then after that sits in for a period, a cystoscope is entered into your bladder through your urethra, so like a small catheter. Inject a small amount of Botox into the bladder muscle, which usually lasts 6 to 9 months. Sacral nerve stimulation. There are 2 companies that we use for this. They're both very good. How this works is it's basically a nerve stimulator. I consider it like a pacemaker to your bladder. It's actually placed on your backside. And so we're accessing the S3 nerves to send a signal to those nerves to basically normalize the pathway and signaling from your brain to your bladder. It's very interesting because it's not just telling someone's overactive bladder to slow down, but we also use it for people who have difficulty emptying their bladder or an underactive bladder. And it works for both scenarios. This is done as a trial. And after a week trial, if it works, which it will for 80% of folks, they'll have 50% or greater improvement. We put a battery in, and that battery is good for 10 to 15 years. Posterior tibial nerve stimulation. So this is one of the newest options for patients. We have offered for years a treatment that you come into the office to do, and we actually stimulate a small nerve in your ankle. And this was done in a series of weekly sessions for 12 weeks, and then this required maintenance. So now there's a device called AltaViva, which you can insert under just lidocaine, so it doesn't even require anesthetic beyond that. And it's good for 10 to 15 years. But it's a small implant placed in the ankle that's stimulating that nerve, and it can go off as we set it on a schedule at your home. So you don't have to come in for these sessions. So all very good options. And of course, I can't say enough, estrogen will help this as well. So vaginal estrogen creams and inserts can really benefit these symptoms. Stress incontinence. So with this, what we're trying to do is we're trying to strengthen the pelvic floor or increase the tone of our urethra so that little Kegel muscle is not a leaky valve. So pelvic floor physical therapy obviously is a really good place to start. There also is a device called Elitone, which you can order at home. It does not require a prescription. I like this because for those of us who maybe have difficulty sticking to a Kegel schedule, we just need something that doesn't require as much on our end. This is a device where you put little gel pads on your lower abdomen, and then I believe it's your inner thighs, and it's contracting your pelvic floor muscles for you. We may have some background music happening. I'm not sure if you guys can hear that, but we will push on. So Elitone is something you can order online. I also like this because some of the other devices were shaped kind of like dilators or even vibrators. So it's a little bit intrusive for someone to use just to strengthen the pelvic floor, whereas this one is external. Bulkamid, the next item. This is a very popular one because it's one of the least invasive options. Well, it is done in the operating room. It is simply an injection of a water-based gel into the mid-urethra. So in the operating room, a 5-minute procedure where we use a cystoscope to guide us, and we're injecting in 4 quadrants a water-based gel, again, to close things up. Because it is a water-based gel, your body doesn't recognize it as something foreign, so it's not actively trying to push that out. So we have long-lasting results with that. And then most people are aware of the sling. This sling is a single incision sling, or there are other varieties, but there's small incisions in the vagina, and then a thin piece of mesh sits underneath that. And so your collagen grows into that mesh, and it's serving to support the urethra. It's also a quick procedure done under anesthesia. It's about a 30-minute procedure. It's been around a very long time with success rates of 90%. So all good options. So pelvic organ prolapse, I'm going to explain this a little bit, and we won't go into extensive detail on treatment options, but just so women can understand what may be happening. Because often I hear people say, oh, my bladder dropped, or am I leaking because my bladder dropped? If your bladder dropped, you're going to know because it's going to feel like a bulge in the vagina. Sometimes you even have to push it back in. Some women describe that to me as something like they feel like a water balloon or like a tampon is stuck. This affects 40% of women. Only about 11 to 12% probably proceed with surgery, but it is a very popular, or I would say common problem. Increased by risk of menopause, again, because of more weakness in those tissues. Those of us who've had vaginal deliveries or multiple pregnancies, white and Hispanic races, and if we have any situations where like chronic coughs, chronic constipation, where we're straining and pushing down. I also see this in professions where people are lifting heavy. Unfortunately, I see it, and people who just enjoy gardening because they squat a lot, or people trying to get in better shape. All of a sudden, they got a new trainer and they've done a tremendous amount of squats, and now they have pelvic prolapse. So just be mindful of those things as you even are doing things that you consider healthy for yourself. But can present not only as a bulge, but back pain, sometimes incomplete emptying of your bladder bowels. So if the bladder is pushing down, that's what we call cystocele. If the intestines are pushing down, we call it intercele. If it's a uterus, it's uterine prolapse. And if it is the rectum pushing in the back of the vagina, that's a rectocele, which I'll show you a picture on the next slide just to explain that a little more. Treatment, we have pelvic floor, even you just doing simple exercises at home, like Kegels, walking, swimming, biking, anything that helps support the pelvic floor. Again, what you don't want to do is squats. You don't want to do sit-ups, anything that's putting pressure on your bottom half. A pessary is a non-surgical option, sort of like a rubber donut. And what it's doing is it's just a little shelf that keeps things lifted. We fit patients for these so they have the appropriate size. It's something they can leave in for extended periods of time. For 3 months is usually the average, and then we can take it out, put it back in for you, or it's something patients can take in and out on their own. And then, of course, there's surgery. So surgery depends on what part is pushing down. And sometimes it may be one organ, sometimes it may be multiple organs. So I'm going to show you a picture now. So if you look at the first picture, picture A, this is normal anatomy. So the bladder is labeled. So you see bladder in the front. If you see this sort of oval shape in front of it, that's your pubic bone. So bladder, you have the uterus extending down to the vagina. And then the more dilated, the larger organ behind it is your rectum. So again, the vagina is just a pocket. So we're now going to look at picture B. And you can see where the illustrator shows the bladder now is changing shape and it's bulging into the vagina. So essentially, any of our organs can do that. I think the easiest analogy is if you think of a sock and it's like you pull the toe of the sock inside out. That's what's happening to your pelvis. So the next and final menopausal topic will be vaginal atrophy. So this is something where I have women all the time who are like, I'm not even sexually active. It's been a decade. Why do I need to worry about this? Well, not only are you at an increased risk for UTIs and maybe more bladder leakage, but it's not comfortable. Again, for my patients that are listening tonight, I use this analogy all the time. So it's basically like with menopause, your vagina is on the beach and the tide never comes in. So unfortunately, it's like this sad, dry little sponge. And that can be very uncomfortable for us ladies. So you don't have to live with it. During intercourse, sometimes women can have a sensation of tearing. You have a decreased awareness or sensitivity of those tissues. So sometimes it can make it harder for someone to orgasm. They may even notice clitoral atrophy, meaning the clitoris itself gets smaller, and sometimes even the skin around the clitoris or the opening of the vagina can start to narrow or close, which can be very painful and uncomfortable for ladies. This all translates to decreased libido because if it doesn't feel good, there's no positive reinforcement that we want to have sex ever again. So to enhance our relationships, if we are actively involved with someone, you really want to help things feel better. And then if they feel better, sex will not be as painful, and then it may further increase our interest. So a couple options we have there. Vaginal hormones, like we talked about earlier, again, helping with not only dryness, but also the elasticity of the tissue. And then this increasing sensitivity. Pelvic floor physical therapy. This is really important in women who also suffer from some of that tension in the pelvic floor, because with intercourse, what may happen is upon entry, the muscles sort of spasm down. And so sometimes we use things, as mentioned further down the list, like vaginal Valium to help relax those muscles before intercourse. For women who have a very narrow opening, and sometimes that's the simple result of things like radiation or other gynecologic surgeries, we'll use vaginal dilators. Consideration of hormone replacement therapy. So this is referring to systemic hormone replacement. So when I'm talking about like taking your estrogen, your progesterone, your testosterone, and so that can be helpful for women for a lot of reasons, which is a completely different talk, but it definitely can help with libido as well. But again, to improve the vaginal atrophy, even just taking an estradiol pill is not going to do the same as using a cream or a local insert. Compounded options I put on there because sometimes people just have more sensitive tissues, and the name brand creams and inserts aren't going to work for them. We'll have to come up with something a little bit special, very gentle for their tissues. But there are a lot of options, and it's a sensitive thing to talk about. So that's why it's fun to highlight it here, so then you can reflect back on it and come in and chat when you're ready. What to expect when you have some of these issues and you want to come see us. So we try really to keep, especially for our female patients, a mostly female staff. And that includes our nurses and our medical assistants. Um, there's definitely a level of confidentiality and respect because we know that these are things that are really hard to discuss. And we want you to feel comfortable, be open with us because it allows us to better help individualize your plan. As you can see, there's so many variables here. We all have a different past. And many of those things, even early in our life, may influence what's going on now. So your treatment is not going to follow just one standard protocol, but we're going to try to individualize it to what's working for you and at that time in your life. We'll be very straight up with you. If it's not working for you, we're going to move on to something else. So yeah. Hope this was helpful. And I think Jamie's going to lead us through some questions.
Yes, if you haven't submitted your questions yet and you have one about any of the topics, or maybe there's a topic we haven't covered, feel free to put that in the Q&A area of the webinar at the bottom of your screen. But we do have some questions, and I
Okay.
will read those off to you. One is vaginal estrogen safe to use 3 times a week long term?
Oh, absolutely. So I've had patients who maybe they had a history of breast cancer or something like that, and they were very nervous about what this is going to do. So we've actually checked their blood levels to see if their estrogen levels went up when they were using it at 2 to 3 times a week, and it did not. And again, this goes back to there is not systemic absorption with these. For vaginal atrophy, 2 to 3 times a week is usually the dose, but I will tell you, I have some women that I advise them to use it every day. If they're having pain or more dryness, then sometimes we'll have them just use the cream, more generously throughout the week. So yeah, I feel very comfortable saying that it is safe to use. Mistakenly, I can say it like this. The FDA had a label, a warning label on all of those products that said may cause increased risk of ovarian, breast, uterine cancer, stroke. Those were appropriate if someone was considering systemic hormones. So, like if I was taking an estrogen by mouth or a patch, and again, that's sort of a different discussion because we still don't think those risks are as great as they once were, thought to have been. But the FDA within the past year has agreed to take off those warning labels from the creams and the suppositories that you're referring to.
A follow-up question to that was, what is the best way to apply it?
Ooh, good. Um, I like to tell people if they're using a cream, I think the applicator is very, very messy. Usually I tell people to just apply the cream directly, like your last knuckle to the fingertip down. So it's going to be about what you would put on your toothpaste. And then you spread the labia because it's not really like the skin on the outside where hair may grow or used to grow, but you're going to go into what I call the entry point. It feels like kind of like a hard circle right there. And then even around the urethra is fine. And if you're wanting to enhance perhaps clitoral stimulation, go right over the clitoris there as well. If I have someone that says it is helping, but I still kind of feel dry on the inside, sometimes those people will mix it up and they may actually insert with a plunger intravaginally, maybe once or twice a week. And then the other times a week, they'll use the fingertip method.
Another question along these same lines is that this particular patient says she was ordered bag estrogen and the application device can't empty such a small amount. So she
Mm-hmm.
just puts a dab on her finger on the outside. Is that okay?
Totally fine. And it comes down to the pharmacy won't fill a prescription unless we put an amount. So usually we put like 0.5 grams or 1 gram. But that's why I think it's just easier for patients to apply on the fingertip and do what works for them. And again, different conditions may require different amounts. So if you're just maintaining your vaginal health or preventing UTIs, you may not, maybe a pea size amount is fine. But if you are coming to the situation with lots of vaginal pain, maybe you've had a prior episiotomy, radiation to the area, the tissue is very sensitive, you may need to apply a little more liberally.
Okay, thank you. This participant is asking, she doesn't have pain during intercourse, but
Mhm.
about an hour afterwards, and it feels like a UTI type of
Mm.
feeling, but what could that be?
No, those are a little bit tricky because sometimes after intercourse, what can happen if it's more bladder symptoms, for example, more frequency, urgency, pressure, maybe even a little burning, you can have a little rise in bacteria. Then maybe it doesn't transition to a full-blown UTI, but I've had a lot of folks where that can be just like the beginnings, if you will, of a UTI, which can cause some discomfort. The other thing it can be is sometimes you can have, um, it's almost like a pelvic floor spasm that can happen afterwards, and that's going to feel more like a cramping, a contraction, but sometimes also increased bladder sensitivity as well. So, usually in that situation, it's a little bit of a trial and error. We try to address both sides of it, and then the patient helps us figure out, what was the main cause just based on their results. For example, if we use an antibiotic around the time of intercourse, or maybe we try something like vaginal Valium afterwards to help things relax. But yeah, those are a little bit confusing sometimes.
This is another great question. She's asking if she needs to wait any particular amount of time in terms of
Mhm.
days before, after applying vaginal cream before having sex, and
Oh,
does
yeah.
does it impact or affect her husband?
You can tell him whatever you want. Um, but my answer is no, it will not affect them. Men have estrogen too. And in fact, is sometimes we talk to our male patients about a certain level of estradiol is important for them for their own sexual function. Now, I'm not giving them estrogen, but just so you know, it's totally safe. It's not going to be absorbed by your partner. I have had patients ask me, with oral sex, is this a problem? No, it's not a problem. I mean, I can't tell you the details of how that's going to go for everybody, but it's not going to make anyone have any terrible levels of hormone absorption. Oh, and how long after? Um, I mean, to be fair, if you put it in and then you guys had intercourse, it's totally fine. There was actually a company, one of the vaginal inserts, and the rep for that company, just because she felt that it made intercourse feel more pleasurable, she used to put her insert in, an hour or so before intercourse. So there's no wrong way to do that.
Another question is how do we know if we have an estrogen imbalance that we might need something like this?
Oh, yeah. So I would say if you have been a year without your period, or obviously if you've had a hysterectomy, um, and we call it surgical menopause, a total hysterectomy, then you would know that you're clearly not making hardly any estrogen. Again, the average age is 51, but the pre-menopause or perimenopause years, it's a little hard to figure that out because you may have your period several months in a row, and then the next month you may not, but you start to feel symptoms of hot flashes. I'm a little more distracted, fatigued, more vaginal dryness, maybe more UTIs. I would consider all of those indicators is, yeah, we probably should check. Um, the the way we approach this now is even if your numbers are not decisively in the menopause stage, sometimes we still will treat with hormones to see if you feel better. Because again, the risk of hormone replacement is very low for most women. So you go by symptoms, use the numbers to sort of support those decisions, but it doesn't, we don't base everything exactly on what your labs may show.
There's a few bladder related questions. One is,
Yeah.
um, does a hysterectomy have any impact on weakening the bladder?
A hysterectomy can put people at increased risk for prolapse. Um, Hysterectomies often come with menopause changes for a lot of folks, which again, when there's less estrogen, it can make the bladder more overactive. So I would agree entirely. And with weakening of the pelvic floor, that can result in more coughing, sneezing type leakage, as well as more overactive symptoms as well.
Another is there any benefit to vaginal DHEA for
Mm,
overactive bladder?
You know, so Interrose is a product we use a lot, which is not estrogen based, but it's basically a DHEA. It's still an androgen that acts on estrogen and testosterone receptors when put in the vagina. So they do not have studies to show that it does definitively improve the overactive bladder symptoms. But I can say this, if you think of it as you're improving tissue strength by using those types of things, then yes, it can result in some improvement. Is it going to be as good as directly using estrogen? I think there will be some, receptors that are probably responsive to that, but I can't tell you for sure if it's as good as a direct estrogen product.
There's a couple of questions about some supplements and some medications uh,
Mm-hmm.
affecting bladder and bladder control. So, a couple named were melatonin and NyQuil. And does that affect my ability to pee after I wake? And does
Mm-hmm.
it have any lasting effect on muscles when it relates to?
Yeah, I don't know about melatonin. Um, but I would say this. I've been doing urology for a really long time, and I have not once come across a patient where melatonin has seemed to be the cause of them having issues with retention or difficulty emptying. Now, NyQuil and specifically any medication like an antihistamine type medication, allergy type meds, those definitely can slow down the bladder. And just to expand on that, any muscle relaxants, pain medications, anything that can slow down, cause dry mouth, can cause constipation, is also going to put you at risk for slowing the bladder down too.
This is a great question. This patient tried Bulkamid,
Mm-hmm,
3 weeks, had no leaks, and then
mm-hmm.
started leaking again, and
Yeah,
went back in. Option was to try it again, but
yeah,
really has some confidence questions. What would you
yeah.
suggest?
Yeah, it's hard because Volkamin is very effective for a lot of women. But just to kind of lay out the stats there. So, in their initial studies on Volkamin, if I recall right, it was something like 64% of women were completely pad dry. But 92% of women, if you asked them subjectively, said that they were improved to the extent that they would do it again. Now, with that said, usually I have about one patient a year that we are doing what we call a top off or repeating their Bulkamid. So I guess two thoughts. One is it's an easy thing to top off, and I've had a lot of patients that have been successful with a second injection, and it's very low risk. On the other side, if you've already sort of delineated yourself like it didn't respond the first time, is there 100% chance it's going to work the second time? Unfortunately, I can't say that there is. So it's sort of just looking at the severity of your symptoms and asking yourself, like, is it worth me trying that again? Which sometimes comes down to where you are in your life and insurance coverage and those things, versus moving on and doing a sling. Which prior to Bulkamid, to be fair, we did way more slings because it was the more definitive option. When Bulkamid came along, their success rates were very, very well or were very good. But the sling's still a really great option. It is minimally invasive. It's just a little bit more recovery time.
Um, Another great question is I don't have a major leak problem, but I do
Yeah.
leak enough to where I feel like I have to wear a pad or it would show through like my
Mm.
my pants. Um, but is that just like again something normal or should I come in? Is there solutions for something that's a small leak like that?
Yeah. I think what you should do is really do a home bladder diary. For 2 weeks, just outline how often you're leaking and try to figure out, is there anything at home you can change? For example, if it only happens after you have coffee, or if it only happens on a full bladder when you sneeze, try to differentiate if it's a coughing, sneezing activity type leakage or leakage without notice. Um, and then if you look at that, and if you can identify a pattern, maybe it'll help you identify something you could do with lifestyle. Might as well go ahead and start doing pelvic floor strengthening in the meantime. And I apologize, guys. I'm going to grab my charger because I moved it over to another site. So one quick second.
No problem. I'll just say if anyone is on and you have a question that you're holding, just be sure to put it out there. You can use the Q&A button at the bottom of your Zoom screen. So be sure to submit your questions. And because we have another, 5 minutes. And so get those top questions in.
Okay, I'm back. Thank you for the pause. This is what happens at the end of the day. So if you identify something that you're like, oh, I can't really figure this out, and it's not maybe necessarily related to hormone changes or medication changes. I didn't bring that up earlier, but I should. For example, any recent diuretics. A lot of people on some of the new weight loss medications are having more constipation. And so that constipation can simply translate to them not emptying as well. So if you don't find anything obvious, yeah, I would say come in. This talk went through a lot of things, but if you come in, we can analyze your urine, make sure that there's not any indication that there's something else going on. And we also often do a bladder scan to help make sure that you're emptying well. Every once in a while, we'll find someone that has that type of leakage where it's not really terrible, but they're surprised and we're like, oh, wow, you're not emptying your bladder like we thought you were. So maybe if we focus on that. If it's not a quick fix at home, boogie on in.
Um, One participant is asking if you could repeat the DHEA estrogen you mentioned.
Yes. Yeah, so there's a product which we like. It's called Intra Rosa. So this is not estradiol inserts, but it is used for vaginal atrophy, and it's very effective. So it's basically an androgen-based insert, so sex hormone, and when you put it in the vagina, it acts on estrogen and testosterone receptors. And so the benefit of that is you are getting help with improving the vaginal pH, vaginal atrophy, but they also show in their studies increased arousal and those things as well. So it's a really good option for women and also very safe.
One question is about a bladder sling, and the question is usually how long does it last? Because this particular patient had her bladder drop, had a total hysterectomy,
Okay.
and bladder repair 27 years ago. She's now 69,
Mm-hmm.
and her urine stream is getting very slow, getting hard to urinate, which she's been told her bladder is kind of tilted. So someone
Mm.
mentioned her bladder sling may be wearing out. Is that possible?
Oh, so I would say the bladder sling, again, the indication for that is coughing, sneezing, leakage. A lot of times, what was done historically with surgeries is sometimes when a woman had a hysterectomy or a prolapse repair, it would almost have been put in prophylactically, but it could have been at the time you also were having coughing, sneezing, leakage. Once that sling is in, it is in. Like actually within the first couple months, if I was to go in and take it out, it is really hard to take out. So it's very, very unlikely, with that time span from your surgery to now that the sling has moved at all. I think it's probably just that something has changed. Maybe, and I hope not, but perhaps the bladder has fallen back down a little bit. Um, Other reasons the bladder may not be emptying as well beyond recurrent prolapse is if the opening to the urethra has atrophied and it's a little narrow, which is not super common, but sometimes women can develop strictures of those. And what we would do is basically we would put a little camera in or just insert a catheter to make sure that there's no problem with obstruction. The other reason you may have problems emptying is if you're more constipated, again, any of those medicines we mentioned earlier, or your pelvic floor muscles are too tight. So you want to make sure when you're trying to urinate, relax and even put a stool in front of your toilet. So like a little footstool or squatty potty. And that will kind of elevate your knees above your hips. And then you let your knees fall open like a grand plie or a butterfly. And then you lean forward and blow out. That will help relax the pelvic floor. Sometimes it can be the result of other medical conditions. People who have difficulty emptying their bladder, it can be because the nerves aren't sending the correct signals to let the bladder contract very effectively. So diabetes, certain peripheral neuropathies, multiple sclerosis, even Parkinson's can sometimes be challenging because the bladder is very overactive, but it also makes the muscles very spastic. So in short, I think, my dear, you need an exam and then also for us to do a bladder ultrasound to make sure you're emptying okay and make sure that there's no evidence of narrowing there.
Right. Well, we have time for one more question, and I'll combine a few. There's several participants that have asked about vaginal probiotics and
Oh,
if
yeah,
those are good, and if there's something you would suggest. What?
sure. So yeah, there's so much on the market. It's really hard to navigate what's good, what's not good. Um, a good one, and to be fair, you don't have to put the probiotic in your vagina for it to work. There are several good oral ones which have been studied to ensure that the types of bacteria in that probiotic are actually ending up in the vagina. So don't feel obligated to buy one that's a suppository. Um, Refresh, it's like REPH rather than F, is a good one that's easy to find. I really like the one by the company Bonafide, and you don't need prescriptions for any of these, but it's called Clairvy. I like that one because you take it 15 days on, 15 days off, and that company actually has data to show that it does help. And not only in reducing like bacterial vaginosis, yeast, UTI things, but they've actually done studies on odor. It's kind of a sensitive topic, but hey, while we're all here, why not close it out with this? Um, with changes in menopause, the pH, sometimes there can be kind of a funny odor. And I have had spouses actually ask me about it for their loved ones. That product, the Claire V one, can be very, very helpful for that. Another is the Metagenics one. That's a very good one as well. If you have one you like, I know there's one called, I think it's like Natural Life. A lot of women like that one. But yeah, it gives you at least a few to choose from.
Great. All right. Well, it is time to wrap up. Dr. Hardee, is there anything else that you want to share as we close out this evening?
I would just say thank you all because I know many of you are my long established patients, and I know you have a lot going on in your life. So thank you for listening to things you may have heard me say 1,000 times. But if you're coming in, that means you're already an empowered, educated lady on these things. What you can do is pass it along to maybe family, friends, because again, I became a urologist because in short, it affects everyone. And I feel like as women, sometimes our issues are kind of pushed to the side because we're pushing through with our careers, taking care of children, all of that, or other health issues. So, yeah, don't be afraid to chat with a friend about it. Or if you know she's going to the bathroom a lot, just let her know, like, hey, there are options, and all of this will be done very delicately. We'll do our best to make people feel comfortable. Oh, I guess one final note also. I know we did a little bit of an hour here. We really try to make sure by the time you leave your appointment that you know what's going on and that you're happy with the plan. With that said, I am not always on time, but I promise you it is not because we are eating bonbons and playing on our phones. Um, but yeah, you will leave feeling that you have a plan you like. And if it doesn't work out, we'll never give up. So yeah, I guess that's it.
Awesome. Well, you can visit urologyaustin.com to schedule an appointment. The phone number is here on screen, but it's also on the website. Don't hesitate. If you have questions,
Yeah,
I think the best is make an appointment.
do it.
Make that appointment, talk it over. I know Dr. Hardee would love to see you, and there's also
Yeah.
other great
We
providers
have
as
a
well.
great team. We have a really, really good team right now. So we'll be
All
happy
right,
to.
everyone. Thank you so much, Dr.
Yeah,
Hardee. Thank you for your
pleasure.
time and sharing this content with us all tonight. And
Yeah.
everyone, have a great evening.
Okay. Take care, everyone. Bye.